All right, let's jump right in. We've got some really detailed revision notes here from a listener, all focused on anterior spinal artery syndrome, which is, well, quite a condition. Imagine, sudden paralysis, losing that ability to feel pain or temperature, but you can still feel touch. It's that strange pattern we're diving into. So our mission today is to take these notes you shared and really unpack them. We want to sift through, pull out the absolute high-yield stuff, the key facts you need maybe for revision, or just to get a good handle on the specific and thankfully quite rare neurological issue. Think of it as your focus guide to anterior spinal artery syndrome.
Yeah, and it's definitely worth understanding because at its core, like these notes say, it's all about the spinal cord. It happens when the blood supply, specifically from that anterior spinal artery, gets blocked, basically. Disrupted. It's not common, no, but the notes are right to stress how severe it can be, the impact, the long-term stuff.
Okay, let's unpack this then, starting right at the basics based on these notes.
Yeah.
What exactly is anterior spinal artery syndrome? What's the definition we're working with?
So the notes define it as a rare neurological condition. And the cause is occlusion, a blockage of the anterior spinal artery. Simple as that. And this blockage leads to ischemia, which is just lack of blood flow, which then causes damage or infarction, tissue death in the spinal cord itself.
Right, and the location supplied by that artery is key, isn't it?
Exactly. It mainly feeds the front 2/3 of the spinal cord. And the notes are specific here. This includes really important pathways. The spinothalamic tracts, they carry pain and temperature signals. And the corticospinal tracts, vital for voluntary movement, plus some autonomic fibers too.
Ah, okay. So because those specific pathways get hit, the symptoms, the deficits are quite distinct.
Precisely. The damage there translates directly into that clinical picture the notes describe. You get loss of pain and temperature sensation, always below the level of the damage, loss of voluntary motor function, so weakness or even paralysis, and autonomic dysfunction, things like problems regulating blood pressure, often hypotension.
Okay. And the notes mention a common trigger for this blockage, something about the aorta.
Yeah, they highlight that often the root issue is a disruption somewhere in the aortic blood supply, because that's sort of where the anterior spinal artery branches off from indirectly.
And the notes, well, they don't really sugarcoat the severity, do they? Even right at the start.
No, they don't. They state it clearly. It's linked with high mortality, often a poor long-term prognosis, and yeah, frequently leads to permanent disability, which is why getting the details right is so crucial, if you're revising or needing to spot this.
Okay, so that's the what? Serious stuff. But why does it happen? What causes this blockage? What's the etiology, according to the notes? Why does this artery get blocked?
Well, the most common cause mentioned is atherosclerosis, the hardening and narrowing of arteries. That whole process can lead to blood clots forming or bits breaking off emboli, which then travel and block smaller arteries like this one.
But it's not just atherosclerosis, right?
Right.
The notes listed other things.
Yeah, correct. Atherosclerosis is the big one, but not the only one. The notes also mention trauma, direct injury to the spine or maybe the aorta, artery dissection or rupture of the artery wall itself tearing, vasculitis, which is inflammation of blood vessels, also compression from the outside like a big herniated disc or a tumor pressing on the cord or its blood supply, and systemic vascular diseases, things affecting blood vessels all over the body.
Wow, okay. Quite a range of potential causes. So who's most likely to run into this? What about risk factors? What do the notes say there?
The notes give a pretty standard list, but it's important. Things that make someone more vulnerable, like advanced age, having a history of atherosclerosis already, conditions that damage vessels so, hypertension, smoking, high cholesterol, hyperlipidemia, diabetes, those usual suspects, having existing cardiovascular disease generally. The notes also flag conditions that make clots more likely, like atrial fibrillation. And, as we mentioned, a history of traumatic injury to the spine or neck. They all basically increase the risk of those underlying causes we just talked about.
Okay, now this is where it gets really interesting for me, connecting the dots. How does blocking this specific artery lead to that specific set of symptoms? Let's dig into the pathophysiology.
Right, so the notes really emphasize the anatomy here. The anterior spinal artery supplies the front 2/3 of the spinal cord. That's the key takeaway. And why that matters, as the notes detail, is because that anterior part houses those critical tracts. The corticospinal tracts for movement, the spinothalamic for pain and temperature, and those autonomic fibers.
So cut off the blood supply there and boom.
Pretty much. Occlusion means ischemia, no oxygen, no nutrients, and that quickly leads to infarction, irreversible tissue death in those parts of the cord. The result of that tissue dying in those specific areas is exactly what you see clinically. Loss of motor function, those specific sensory losses, pain and temp below the lesion, and the impaired autonomic functions. The notes are clear, though. The severity really depends on where the blockage is along the cord and how much tissue is affected. Higher up means more deficits.
Makes perfect sense when you map the artery's territory to the symptoms.
Yeah.
Okay, but sudden weakness, sensory changes, could be other things too. What else needs to be considered? What are the main differential diagnoses the notes mention?
Yeah, good point. The notes list conditions that also cause acute myelopathy, that sudden spinal cord problem. So the main things to rule out are spinal cord compression, something pushing on the cord like a tumor or a bad disc herniation. Transverse myelitis is on the list. That's inflammation of the cord. Guillain-Barré syndrome gets a mention too, though the notes rightly point out it's usually more of a peripheral nerve issue. An acute inflammatory demyelinating polyradiculoneuropathy, quite a mouthful, but it causes acute weakness, so it's on the differential list.
Right.
And then spinal cord infarction from maybe a different artery or other sort of vascular or ischemic spinal cord problems.
In that point you mentioned about using MRI later to distinguish from things like cauda equina or compression, that seems crucial here for sorting these out.
Oh, absolutely. MRI is key, not just to look for the signs of ASAS, but critically to rule out that compression or see if it looks more like inflammation, like in transverse myelitis. It helps separate these possibilities.
Gotcha. And just quickly, how common is this? The notes mention epidemiology in the UK.
Yeah, the main point there is just that the actual prevalence isn't well known. It's considered relatively uncommon, so important to know about, but not something you'll see constantly.
Okay, let's paint a picture. What does this actually look like in a patient? What are the typical clinical features the notes outline?
The number one thing emphasized in the notes is the sudden onset. It's rapid, not gradual. We're talking minutes to hours. That's critical for recognition.
Okay, sudden. And the
Yeah.
deficits.
We've touched on them, but to list them out from the notes: weakness or paralysis, limbs below the level of the lesion, sensory loss, but again, it's specific, impaired pain and temperature perception is the key. Often loss of bladder and bowel control too because of those autonomic pathways. And other autonomic signs like orthostatic hypotension, that dizziness or blood pressure drop when standing up, sometimes issues with sweating too.
And here it is, the really high yield bit for exams, or just remembering this condition, right? That sensory split.
Absolutely. The notes are very clear. A critical feature is the preservation of light touch, vibration sense, and proprioception, knowing where your limbs are in space. So lose pain and temp, keep light touch and vibration. That's the classic pattern. A must know. The notes also add that sometimes the very first symptom might just be sudden, severe back pain right at the level of the cord damage.
Okay, so someone presents like that sudden onset, that specific sensory loss. How do doctors confirm it's ASAS and not one of those other possibilities? What investigations are key?
Well, it always starts with the clinical picture, right? A thorough evaluation, neurological exam testing reflexes, strength, all the sensations carefully. But then imaging is absolutely vital. MRI or CT scans to actually look at the spinal cord. And the notes highlight MRI of the spine as the gold standard investigation here.
And there's a specific sign they mentioned.
Yes, another high-yield detail from the notes. On specific MRI sequences, T2-weighted images, you might see this characteristic pattern in the anterior cord called the owl eye sign. It looks like, well, owl eyes. It strongly suggests ischemia in that anterior spinal artery distribution. And like we said, the MRI is also crucial for ruling out compression or distinguishing ischemia from inflammation, like transverse myelitis.
Makes sense. Any other tests?
Yeah. The notes mention others that might be done. Blood tests, looking for risk factors, lipids, clotting factors, maybe autoimmune markers. Electrophysiological studies, like nerve conduction studies, might sometimes be used, and a lumbar puncture, a spinal tap, could be done mainly to rule out infection or inflammation, though it might show some general signs of cord damage too. But the notes really stress that clinical suspicion, recognizing that pattern early, is key for getting things moving quickly. Time can be a factor, depending on the cause.
Right. So if the diagnosis is made or strongly suspected, what's the plan? What's the management approach? The notes split this into prescribing and non-prescribing.
The main focus, according to the notes, is supportive care and trying to address whatever underlying cause led to the blockage, if possible. But here's the really critical point the notes make. There's no specific treatment that can actually restore blood flow directly to those damaged bits of the spinal cord once the infarction, the damage, has happened.
Wow, so the damage is largely done.
Pretty much, which really highlights why prevention and spotting risk factors is so important.
Okay, so let's look at the prescribing treatment options mentioned.
It really depends heavily on the cause. If it's thought to be from an acute clot, say from atherosclerosis, the notes do mention thrombolysis clot-busting drugs. But, and this is a big, but that's only potentially helpful in a very narrow time window, often stated as 4.5 hours from when symptoms started, and it's not suitable for everyone or every cause.
So a very specific scenario. What else?
Other medical treatments include things like antiplatelet drugs like aspirin to help prevent more clots, 5E fluids, and maybe vasopressors drugs to support blood pressure, especially with that autonomic dysfunction. And anticoagulation, blood thinners, are usually needed both short and long term. The notes mention steroids have limited evidence but might be considered right at the start, though it's not standard therapy.
Okay, and given there's no direct fix for the cord itself, that non-prescribing management sounds incredibly important.
Oh, it's absolutely central to long-term care. It's all about preventing secondary complications and trying to maximize whatever functional recovery is possible. So the notes list things like mechanical measures to prevent blood clots, like DVT, especially when someone can't move much. Extensive rehabilitation is crucial. Physio for movement, occupational therapy for adapting daily tasks, maybe speech therapy if the lesion is high up affecting breathing or swallowing.
Right.
Managing complications is key bladder issues might need catheterization. Respiratory support, even mechanical ventilation, might be needed for high cervical lesions. And the notes emphasize needing a whole multidisciplinary team: neurologists, rehabilitation doctors, physiatrists, therapists, nurses.
Given everything we've said about severity, what's the outlook typically? What the prognosis like?
The notes describe it as guarded, which basically means, approach with caution, outcomes are uncertain, and often lean towards being less favorable. Unfortunately, complete neurological recovery is rare. That said, the notes are clear that significant functional improvement is possible with really good supportive care and intensive rehab. But residual problems, long-term impairments, they're very common.
And what sort of long-term issues or complications might people face down the line?
It's a long list, sadly, reflecting how much the spinal cord controls. The notes mention things like chronic pain, persistent muscle weakness, ongoing sensory issues, problems with bladder, bowel, and sexual function. That orthostatic hypotension can persist. Respiratory issues. Big risks from being immobile include pressure sores and deep vein thrombosis, possibly leading to pulmonary embolism, muscle contractures, where joints get stiff, and importantly, the psychological impact depression, anxiety are common. And as you'd expect, the notes say the risk and severity of all these complications really depends on how bad the initial cord damage was. So ongoing monitoring and prevention are vital.
Okay. We have covered a lot of ground from these notes. If someone listening is trying to nail this down for revision, what are the absolute key high-yield takeaways they should lock in?
Right. Based on how the notes emphasize things, definitely that sensory pattern, loss of pain and temperature, but crucially, preservation of light touch, vibration, and proprioception. That dissociation is classic ASAS.
Got it. Sensory split. What else?
The sudden, rapid onset, that's key for spotting it. Diagnostically, remember that owl eyes sign on the spinal MRI. That's the characteristic finding to look for.
Okay. Owl eyes on MRI.
Management-wise, the big thing is no direct cure for the damaged cord tissue itself. So it's all about supportive care and intense rehab. And remember that very limited window, that 4.5 hours for thrombolysis if it's the right kind of cause. And finally, I'd say connect the symptoms back to the anatomy. Knowing the anterior spinal artery feeds the motor tracts and the spinothalamic tracts, it just makes sense of why you get weakness plus that specific pain temp loss. Understanding the why helps it stick.
So pulling it all together, we've really dug into anterior spinal artery syndrome using these detailed revision notes. It's definitely rare, but it has its very specific way of presenting itself, all stemming from that blocked artery. It poses real challenges for diagnosis and management, and often leaves a lasting impact.
Absolutely. And whether you are revising for something like the MSRA or just want to broaden your medical knowledge, getting a handle on that sudden onset, the unique sensory findings, the role of MRI, and the fact that management is primarily supportive, that's all really valuable stuff from these notes.
It is complex, for sure.
Yeah.
And digging into it like this really shows how interconnected everything is, doesn't it? How vulnerable the nervous system can be to just a plumbing problem, essentially. If you found this deep dive approach helpful for getting your head around tricky medical topics, you might find more resources over at PastTheMSRA.com.
And also, freemsra.com. Both have great stuff for study support.
Definitely check them out.
Understanding conditions like this, even the rare ones, it really underlines the critical importance of vascular health for, well, everything, especially the central nervous system. Makes you think, doesn't it?
It really does. Well, thanks for joining us on this deep dive. Keep exploring.
See you on the next one.